So welcome everyone. Today's session is how to help your patients quit smoking. It's the third of our three-part series on a breath of fresh air, updates in asthma and COPD in primary care. This series is hosted by the Physician Learning Program and the Office of Lifelong Learning here at the University of Alberta. And my name is Denise Campbell-Scher. I'm the Associate Dean of the Office of Lifelong Learning and Physician Learning Program, and I'm a family physician here in Edmonton. The PLP creates clinically actionable information by engaging with physicians, teams, partners, and patients to co-create sustainable solutions to advance practice. The PLP is dedicated to moving evidence into practice and fostering a cultured environment when everyone works together to tackle our most pressing problems, advance patient care, and create a world-class sustainable health system, which includes important topics such as the one today. I also just really want to highlight to everyone, we're so excited for our upcoming PLP Summit, which will be June 11th here in Edmonton. So please check out our website at the Office of Lifelong Learning for a link for registration. Hopefully we'll see you there. Now, we'd like to acknowledge today that we are gathered across Canada on traditional territories of the many First Nations, Métis, and Inuit whose footsteps have marked these lands for centuries. In terms of some logistics for this evening, if you have any questions for our speaker, Dr. Dayna Lee-Baggley, please use the Q&A feature of the Zoom on the bottom of your screen. If you have technical questions, please use the chat feature. Please review what's already been asked and upvote questions, those questions you'd really like to have answered. And we cannot guarantee that Dayna will have the ability to answer all of your questions today. In terms of webinar housekeeping, everyone who registered will receive a copy of the webinar, as well as a PEARLS document with resources. MainPro Plus participants may earn certified credits by completing a linking learning exercise. And MOC and MainPro Plus credits can also be earned by completing a personal development activity using the MyL3 Plan tool. And we'll talk a little bit more about the MyL3 Plan tool at the end of the webinar, but you can scan it here to get to that web page for how to engage in those activities. This activity has not been formally reviewed by the CFPC or Royal College, but it is also eligible for non-certified credits. And in the chat function, I believe Nantony's just shared a link to the conference as well. It's my very great pleasure to introduce to you today Dr. Dayna Lee-Baggley, who's going to be helping us with how to help your patients quit smoking. Dr. Lee-Baggley is a registered clinical psychologist in British Columbia, Alberta, Ontario, and Nova Scotia. She worked for almost 15 years in multidisciplinary teams on medical, surgical, and cancer care hospital units with patients with chronic and life-threatening health conditions. She also conducts research at Dalhousie University and St. Mary's University with an active research program on behavior change, obesity, chronic disease, professional resiliency, and acceptance commitment therapy. She has over 55 peer-reviewed publications, 140 scholarly presentations, and she's an internationally recognized trainer in acceptance and commitment therapy. She's the author of a great book, Healthy Habits Suck, How to Get Off the Couch and Live a Healthy Life Even If You Don't Want to. And she's the co-founder and chief scientific officer of the Impact Me app, which helps people integrate acceptance and commitment therapy into their everyday lives. So welcome, Dayna.
Thank you. Thanks so much for having me. So today I'm going to be talking about how you can help your patients quit smoking. So our learning objectives are to review concepts of readiness for change and how to assess, explore best practices that match different levels of readiness, and to review evidence-based strategies to help your patients quit smoking. So just to start out, this is probably information you've heard before, but as a reminder that part of our brains were built for survival times, includes, automatic thoughts, learning, memory, emotions, appetite regulation, pain regulation, gives you awesome advice if you're a cave person and your life expectancy is 30, and functions automatically and unconsciously. So you can't do anything to turn on this system or to turn it off. The other relevant part of our brain for our discussion is our prefrontal cortex, or our frontal lobe. This is a spot for executive functioning, which is things like starting behavior, stopping behavior, planning, delaying gratification. This allows us to control behavior. So this is where willpower and self-control come from. But unlike our survival mind that's always working, our frontal lobe is like a battery. And so we will wear out that battery of self-control as we use it up during the day. So it's just a reminder that basically any healthy habit or healthy behavior we're trying to get patients to do is going to go against our survival brain. Our survival brain is going to pick stuff that feels good in the short run. It doesn't care if that's going to cause a long-term damage in the long run. It's all about what's going to work right now. And so almost all the healthy habits that we are encouraging patients to do require your frontal lobe battery to do. They are not things that your survival brain is automatically going to encourage you to do. So we're going to work through this via a case study. We're going to meet John Smith. He's 45. He's an accountant. He's married with 2 kids and has a medical history of hypertension and mild COPD. He has a smoking history. He's been a smoker for 25 years, approximately 1 pack per day. So in particular, what we're going to talk about today is readiness for change. And this is part of motivational interviewing about how we understand readiness for change and then match up the readiness with different interventions. So readiness is a state that fluctuates over time. And so it is actually possible to assess readiness and do things that might change people's readiness. So natural readiness happens when the current situation is a problem, the problem causes distress, there's an interest in change, and now is the time to do it. So basically, both your frontal lobe and your survival brain need to think it's a problem. Your logical brain thinks it's a problem, your emotional brain thinks it's a problem. You want to change, and you want to change now. And so these 4 conditions become the questions in a readiness assessment. And so in a readiness assessment, we want to ask, do you consider the behavior a problem? Are you bothered by the behavior? Are you interested in changing the behavior? And are you ready to change now? And so these 4 questions become our readiness assessment. When people are green light for change, so we talk about this like a traffic light, then they are green light for change, they're ready for change. Ambivalent means is yellow light, and not ready is red light. And so this matches up with Prochaska's model of change, but it's an easier concept to understand because people can be red, yellow, or green, and they're all normal states to be in. They also will change back and forth for reasons that are often way outside the control of the healthcare provider. You might have a patient who's totally red light for change, and suddenly their uncle gets diagnosed with cancer, and now they're green light for change. And so it helps to keep that in mind because we need all of these things to be acceptable and okay states to be in. Otherwise, your patients will just lie to you and pretend they're green lights all the time. Okay, so we conduct a readiness assessment with John, and here are his answers. Do you consider your smoking to be a problem? Yeah, I know I should quit. Are you bothered by your smoking? Well, I know it's not good for my health, and my wife is always on my case. Are you interested in changing now? Well, I'd like to, but I've tried before and it didn't work. Are you ready to change now? Well, I know I should, but I have a lot of stress at work right now. And so what readiness do we think he is? He is yellow light, and you can hear that with the classic yes, but. And so basically, yellow light means that they can see positives and negatives to their behaviors. There are still some advantages and disadvantages. And so there's a decisional balance about readiness for change. And so our role is to examine the pros and cons of the behavior. And we want to do that with non-judgmental curiosity. Again, if you don't set the stage where it's okay to be any of these colors, then people will just tell you what they think you want to hear. So behavior change happens when the pros of change outweigh the cons of change. And so there are always going to be things that, are a disadvantage in changing behavior. And what this meta-analysis shows is that the cons don't go away. What happens is that the pros get bigger. And so what we want to think about is what's going to make it worth it for you to do this. The negative parts about the behavior, the costs of change will probably always be there. And so our goal isn't to try to downplay those things, it's to acknowledge them and to try to increase the pros of change. So if you're discussing a yellow light behavior, you always want to start with the pros of an unhealthy behavior or the cons of a healthy behavior. And so if it's an unhealthy behavior, you want to ask questions like, what do you like about the behavior? What is good, helpful, or useful about the behavior? If it is a healthy behavior, then you want to ask about the cons of it. What don't you like about this behavior? What's bad, unhelpful, or problematic about it? So if we go back to our conversation with John, we say, what do you find most useful about smoking, right? Don't start with trying to convince him that he should quit smoking. Talk about the pros of smoking. Well, it helps me manage my stress. Anything else? Well, I think maybe it helps me keep my weight down. Okay, that all makes sense. Is there anything you don't like about smoking? Well, my wife and my kids are always on my case. My daughter tells me that I won't be around to see her graduate if I keep going. Okay, so what we're trying to do here is actually validate the good reasons they have for doing this unhealthy behavior, because there are good reasons. They're probably short-term benefits. They're probably just your survival brain being happy in the moment, but they have logical good reasons that make them feel better. Again, they're short-lived and they have a cost in the long run, but they are doing something. There is a function to these behaviors. So we want to acknowledge that rather than trying to convince them that it's a bad behavior. If we take it in this approach of asking about what's useful about smoking, then once they feel like they feel heard and understood about the fact that smoking has some advantages for them, only then would you ask, well, is there anything you don't like about smoking, right? Because they're yellow light, we know there are some pros and some cons. In this moment, your patient is going to tell you what they don't like about smoking instead of us telling them what they shouldn't like about smoking. So on one of the patients that I worked with, a young adult female who was trying to quit smoking, the thing she didn't like about smoking was that her boyfriend wouldn't kiss her after she'd had a cigarette. Was I going to come up with that as a reason to quit smoking? No, I was not. Right? So they're going to tell you the very specific reasons for them about those pros and cons of the behavior. So tipping the balance towards change is about finding value-driven reasons that add pros to changing. So values in this model have a very specific meaning. They're about how you want to show up as a human. They're about the kind of person that you want to be. They're about how you want to contribute to the world or care about people or connect with people. They're about what you want to give to the world, not about what you want to get from the world. And so they're about how you want to show up. And so often we'll ask questions about, why do you want to quit smoking? And many people will answer things like to be healthier, to have more energy, be more active, live longer. And we kind of stop there and say, oh, good, that's enough. It's not enough. That's not a value-driven question. The value-driven question is, and what are you going to do with those extra years of life, with that extra energy or activity? Why does it matter to be here for more years, right? Once you ask that question, that's when you start getting to values. And it's okay if you don't get to them right away. It's okay if you just plant the seed asking about it and you return to that question later on in a subsequent visit. And so perhaps we ask John these questions, right? And he's probably going to say something based on his last answer about the kind of husband or dad that he wants to be, right? He mentioned that, what's distressing about it is that his kids and his wife are upset about it. Notice that this is not just about the future. This is also about who John wants to be as a husband and a dad right now. So don't focus on, 20 years from now, you'll be able to walk your daughter down the aisle. Right now, you'd have a better relationship with your daughter because she wouldn't be grumpy at you every time you go smoking. Okay, so when we think about carrots or sticks to motivate change, we often focus on the sticks. So we often talk about the bad things that will happen if people don't change. And while that kind of distress can get people started in behavior change, it won't be a reason for lasting change. So if you take the example of, a horse, trying to get a horse to move, if you beat it with a stick, it will move, right? But over time, what does that do to the horse? How does the horse feel about the owner? And if you take that stick away, that horse is not doing anything for you. What values does is it gives you a carrot. It's about moving towards something that matters, not just about getting away from something bad. And moving towards something that matters about your identity, about what's meaningful to you, is the kind of thing that we do all the time. And we do difficult things all the time in the service of being the people we want to be. This is also not about making health a more important value, right? Health is a domain. Health is something that allows you to do something else. And so don't make health a value. What will the health allow you to do? How will it help you show up as the person that you want to be? Okay, so now we'll go back to our case study and we'll do another readiness assessment. Right, so do you consider your smoking to be a problem? And he says, I've heard the smoking lecture before, okay? Are you bothered by your smoking? I know, I shouldn't smoke. Are you interested in changing your smoking? Honestly, it's the one thing I do to relax. I don't really want to give it up. And then you might say, well, I probably know the answer to this, but just to be sure, is it something you want to change now? Like, nope. Right? And so what is his readiness for change? We would call that red light. There's a whole bunch of not yeses and nos in there. So red light is the one that as healthcare providers, we struggle with the most because the actual things you want to do when you are faced with a red light behavior is to take the expectation of change off the table. The goal is actually to maintain the relationship. Because if you continue to try to change a red light behavior, you will actually do harm. You will do harm because people will stop attending medical appointments just so they can avoid the lecture about the thing that they're supposed to change. And so they will stop getting medical care for other things that they might be able to be helped by because they don't want to get the lecture about why they should quit smoking. And so it will actually do damage to the person because they won't get routine medical care. They will skip it. And so I remember once, giving this presentation, and the physician in the audience said, okay, but, I have a patient, she's pregnant and she's on cocaine. Clearly, you don't mean that I should stop trying to change the behavior if she's pregnant and on cocaine. And I was like, is she red light? And she's like, yeah, she's totally red light. I was like, yeah, that's what I'm saying. Stop focusing on the cocaine and focus on things that she is green or yellow light about, because there are a ton of prenatal things that you can do that have nothing to do with cocaine. Do all those other things that she's willing to do, because if you focus on the cocaine and she's not ready, she's red light about that, she will stop getting prenatal care. And she will still be on cocaine and she will show up in the emergency room and it will be a crisis. If you can continue seeing her and helping her with other things that aren't about the cocaine, then you can plan for an admission when she comes to deliver, and you can have services ready to help out this baby as well. But if you try to change a red light behavior, you will do harm. And so in our case study with John, we might say something like this. Hey, sounds like you're red light for quitting smoking, right? It's totally useful to tell the patient about this traffic light assessment, right? Sounds like you're red light for quitting smoking. That means that now isn't the right time for you to work on quitting. That's completely normal. Sounds like smoking is an important way for you to relax, so we don't need to keep talking about quitting smoking. I'm going to keep checking in on it to see if there's any change, but if you're still red light, we'll just focus on other things that are important to you. And so what would you like to talk about today? When you ask that question, chances are they're going to bring up a green light behavior, right? People are not red light. Behaviors are red light. You might be red light for quitting smoking, but green light for exercise. And so if you ask them what they want to talk about, they will bring up things that are important to them. Okay, so we go back and we're doing a readiness assessment with John. So we asked, do you consider your smoking to be a problem? And he says, yes, I really want to quit. Are you bothered by your smoking? He's like, oh, I'm embarrassed about it and my whole family hates it. Are you interested in changing your smoking? Yes, I'd really like to. I just haven't been able to in past attempts. Are you ready to change now? Yes, I'd really like to get this under control. So what is his level of readiness? We're going to call that green light, right? Make sure when you think of green light, it's not these like wobbly yeses. They should be convincing yeses that you're ready to like, you know, bank money on. So one of my colleagues would say, you know, imagine you're proposing to somebody and you say, will you marry me? And they say, yeah, okay. Yeah, that's probably a good idea. I should maybe do that. Right? Would you feel happy about that like proposal? Gonna put that up on Instagram? Probably not. Right? But when we ask a patient, do you want to quit smoking? And they go, well, yeah, you know, I should probably do that. We go, great. And here's all the resources. That's not green light. That was a whole bunch of yellow in there. Okay, so these are convincing yeses. So things that we can do to help in green light interventions, right? So this is, again, where your typical smoking cessation programs can come in is when people are green light for change. One of the things that we have to address most in smoking is the psychological habits around smoking. So there are lots of people who actually do not smoke enough to keep the nicotine in their system consistent. And so they are actually having these waves of cravings, and they are typically tied to locations and places where they typically smoke, right? And so the first part is to change this relationship with the habit about smoking before you actually change the nicotine amount in their systems. And so we would ask questions about the habit of smoking. Where do you typically smoke? What time? In relation to what activities? What brands? We want to get to know what the habits are around smoking. So we might say to John, our first goal is to break the psychological habit of smoking. Are there times of day or places where you normally smoke? And John says, yeah, always outside, usually when I get home from work. And then again after dinner, I take a morning and lunch break and take a smoke break then too. So we might say, okay, so let's start changing that up. Keep smoking the same number of cigarettes, but let's find a way to do it in a different way. That could be buying a different brand. It could be smoking with the wrong hand, finding a different location, or smoking at different times of day. And so what we're trying to break there is the psychological habit around smoking. Then we can think about replacing those habits and addressing the actual nicotine. And so consider nicotine replacements, right? And think about do instead goals. It's very hard to have a don't do goal. It actually creates this effect we call the thought suppression effect, which is that the more you try to not think about something, the more you think about it. The classic one being don't think about pink elephants, and you'll suddenly start thinking about pink elephants. And so have a do instead goal. Rather than don't smoke, what are you going to do instead of smoking? What is the function that smoking does for you? If you use smoking to take a break, then how are you going to give yourself a break in some other way? If you use it to relax, how are you going to find other ways to relax? While acknowledging that these other ways are probably not going to be as quick or efficient as smoking is. We don't necessarily want to focus on distraction, because distraction will only get them so far. As soon as they can't distract themselves, they're going to have waves of craving and thinking about smoking. And so instead, think about value-driven, incompatible behaviors. And what that means is, can you do something that is meaningful to you where it'd be very hard to smoke? So for example, if you were to go, volunteer in a children's classroom, well, you would never smoke in a children's classroom, right? It's incompatible. And if that somehow is really important to you to contribute, to volunteer in a children's classroom, then that would give you a good reason not to smoke because you're doing this value-driven thing. And so there's a difference between a value-driven incompatible behavior than just distraction. We also want to remind people the question isn't if you will fall off the wagon. The question is, how quickly can you get back on? There are a number of studies demonstrating that people actually go through cycles and behavioral cycles around smoking, that many people take multiple attempts. I think the number is somewhere like 11 to 14 times before they quit smoking for good. And so we want to acknowledge that this will happen. And what you're really trying to do is to reduce the amount of time that you're smoking and to lengthen the amount of time you're not smoking. And so we don't want people to think, well, I smoked again, so I just need to give up, right? We just want to say that's the skill here is not, the skill here is to think about how quickly you can get back to your habits. And so start out again the behaviors that you do when you're trying to quit smoking. Okay, we often need to give people skills around managing thoughts and feelings, right? So tracking is about recognizing that our brains sometimes hijack the story and tell us things that aren't really happening through our five senses, meaning our brains will give a storyline that isn't the same thing as what we can see or what we can hear, right? What we can touch. And so sometimes these are like tricks of our minds. And we want to think about managing these thoughts and feelings simply as not true or false, but are they going to lead you towards or away from your values? And so, even just acknowledging a thought as an away thought, acknowledging a feeling as an away feeling can help us change our perspective about whether we want to get hooked by that thought or feeling. There's also a lot of skills we can give people about being able to observe their cravings called urge surfing, which is about allowing the natural wave of a crave to peak and then to dissipate. People often feel like they have to give in to their craving or it'll go on forever. And so teaching people how to urge surf, how to ride the wave of the craving and let it dissipate is another skill that we can get them to do. All of this, is focused on not trying to distract yourself away from thoughts and feelings. It's actually about paying more attention to them, but responding to them differently and not having them control your behavior. Right. So in our case study, we might ask John, what are you thinking about before you smoke? And John says, well, I usually think I'm going to feel better. Like, oh man, I really need that cigarette. And if you slow down and notice, do you actually feel better when you smoke? Actually, not really. I usually feel a bit nauseous and totally embarrassed by my bad habit. Okay, so let's just notice that your mind is tricking you into thinking it's going to feel good, but your actual five senses experience of it is that you feel worse. So maybe you can remind yourself that your mind is tricking you. Maybe you can remind yourself, that it's just a trick of your mind, that you're actually going to feel bad after smoking, not better. Hey, we can also remind people about their values. This is, again, encouraging people to change because it's value driven. It's not getting away from something bad, but allowing them to show up as a person they want to be. So it often feels uncomfortable to change, right? You've mentioned that you have some really value driven reasons for change. Can you remind yourself of that when it gets hard? Maybe something like smoking isn't consistent with being the husband or dad I want to be. I'm used to doing difficult things for my family. Letting this craving pass is just one more difficult thing I do for them, and I'm proud to be showing up as the husband and father that I wanted to be. People are already good at doing difficult things often. They just don't realize that that same skill set can be used to manage this, behavior change. Okay, so in terms of additional resources, so again, this is a science-based app that we've created. It currently works about, the courses are about burnout, but we are adding work on healthy habits and chronic disease. It allows you to track your habits, to be reminded of your values, for example. So we've tried to embed the science of behavior change into the app so that it's a more scalable option to help support people when they're trying to change their habits. This is the book that I wrote called Healthy Habits Suck, which again is, a bunch of information about acceptance and commitment therapy and how we can make use of that to change our habits. Okay, so open up for questions, and that's also how you can contact me or follow me on social media.
Thanks, Dayna. I really appreciate it. Every time I get to hear you speak, I pick up new clinical pearls. So I want us to think about how we can implement this information in our own practices. And studies have shown that when you have more ideas for change, you're more likely to put them into action if you write them down. So the Office of Lifelong Learning Physician Learning Program has prepared a platform to help you make a personal development plan, which will also earn you credits. And the platform is free. It's called My L3 Plan. And the link to the platform is in the chat box. And this is the QR code. So this free tool will let you support those three activities required by the CPSA's Physician Practice Improvement Program, and as well earn CME credits if you're a physician. So this personal development cycle will actually earn you 6 credits. So let's consider a quick example of how you might use this. So if there's something that you wanted to do in your own personal development cycle, what's something you'd like to change? Do you have some supports and resources within your clinic that can help you? So many PCNs have improvement facilitators or quality improvement teams. Do you have one? And how will you measure it if you've achieved the goal to set out to do? And just a plug, so for PLP, you can get data through NAPCRN around some of your disease metrics in your clinic, as well the Health Quality Council of Alberta reports and the CPSA reports can give you places to think about places for change. For clinical things, you might have something professionally. Maybe you want to learn how to be a more effective leader, or you might want to work on a communication skill. Another way for you to get credits is to do the linking learning to practice. And this is through the Main Pro Plus, and you do a reflection exercise. And you can do this with any learning that you do. It's self-administered, self-restructured, and you can get 5 certified credits for this. So the forms are available at the CFPC Main Pro portal. And just before we go on the Q&A, I want to remind everybody that your feedback is incredibly important, because we really take it to heart and we use it to ensure that we're meeting your needs and that we're putting on programming that is valuable for you. So it shouldn't take more than 5 minutes, and thank you. You'll also have an opportunity to participate in a raffle for a $10 Starbucks gift card, which will close a week from today. And so just going to have everybody put questions in the Q&A box. We're a smaller group, so just feel free. I'm going to kick us off, Dayna, just while people are thinking about their questions. I was really interested in this urge surfing, and I'm wondering if you could give us a little bit more of a sense of how that works. And folks, please just type your questions in the Q&A as well.
Yeah, so urge surfing is a skill about noticing your craving, about paying attention to what it feels like in your body and your mind, and then imagining those sensations like a wave. And so you use your breath as like a surfboard that you use to ride the wave of the craving. And so it's about this idea that cravings don't go on forever, that actually they rise and fall like a wave. We're used to kind of giving into them as a way of making them go away, but actually they will naturally subside on their own. Again, in smoking, they're much more likely to be cued by environments or times of day when you tend to be smoking. There's a strong pairing that happens that then creates those cravings and expectation for smoking. And so it's a skill that people can learn. And it's, again, not about distracting yourself away from the craving, because that only lasts for so long. What it is actually about is paying more attention to your craving and responding to it differently. So rather than giving into it, it's about noticing it. It's, again, related to mindfulness skills, right? To notice the craving, allow it to be there in a non-judgmental way. And then allow it to pass, and using your breath to get through that. And so it's been used in a number of different, interventions for various addictions like alcohol, smoking, other things like that, to give people another skill set to manage their cravings differently.
Mm-hmm. And so can you comment on that, Dayna? So if people are on pharmacologic therapy to help them quit smoking, in terms of how that works together with this, what's your experience with that?
Yeah, so typically what the way I describe some of those medications is they're making the wave not as big or last as long. And so that craving, might be bigger, stronger, more intense, last longer, if you have a history of addiction with a substance. And so what that medication can do is to make that wave smaller, less intense, and so that it's easier to use psychological skills to make your way through it. And so it can be very helpful, and we encourage people, the studies suggest that you're going to be more successful if you use some of those nicotine replacement options. And that's what I think it allows people to do, is to, get the wave of that craving into a range where it's easier to manage from a psychological perspective.
Mm-hmm. And can you give us some thought on, I've heard in the past people suggesting that people also make a positive change, like, for example, take the money that they might have spent on cigarettes and put it towards something else that's meaningful or valuable to them. Do those kind of strategies have any impact with this, or is that not as effective?
It is helpful to find a way to reward yourself for the new behavior. the do instead behavior of smoking. And so that is one of the options, of rewarding yourself, is acknowledging that you were spending money on smoking and putting it towards something else that matters to you. Again, if you can find value-driven reasons for change, which are about how a person wants to show up and the kind of person that they want to be, that's a much stronger force kind of than saving for a vacation kind of thing. But it is helpful to reward yourself for the new behavior.
Hmm. And so in the course of this, if you're doing some assessments for alcohol with people, for smoking with people, and you uncover that they say something like, one of my triggers for smoking is when I drink, and then when you start to do a little bit of probing around that, you realize that maybe that's actually in a more dangerous realm as well. Um, how do you tackle when you've got more than one thing going on? If it is really meaningful for them, but it's enmeshed in something else?
Yep. So, typically your best option is to pick the one they are most green light about, right? To pick the one that they are most interested in changing. If they're, green light about all of them, then pick the one that's like the first in the chain kind of thing. So if alcohol leads to smoking versus smoking leading to alcohol, you would pick the first one in the behavioral chain. But it's more important that you pick one that they are more ready to change, that they're more green light on. And acknowledging that, again, you're going to use your frontal lobe battery to change these habits. And so changing too many of them all at once is not that, is difficult. You need enough battery to dedicate towards changing this habit, because your survival brain is still going to be creating those cravings, the cues, the triggers to prompt the addictive behavior. And those will happen, again, unconsciously without, in a way that we can't start or stop. And so making sure people have enough battery for how much change they're trying to make.
Hmm. And how does that play out perhaps in times of very significant psychological stress? Like you gave the example of someone's uncle being diagnosed with cancer, and now all of a sudden they're green light for change. Um, are there times when you as a clinician might be a little bit concerned about that in terms of how much battery capacity they have for change, or how would you handle that?
Yeah, so certainly there are sometimes patients will say, like, yep, I want to try quitting smoking. And you ask about what's going on in their lives, and they're getting divorced and they're switching jobs or they're moving houses. And honestly, I will say, like, look, I don't think this is a great time to work on that. Like, why don't we get through some of these other things in your life first, and then you'll have enough battery to dedicate towards this? Because when people like start and then feel like they just keep failing at it, then they won't start again. They'll just kind of say, "Oh, there's no point in me trying to change. I haven't changed in the past." And so we want to set them up for success. And so that means making sure they do have enough battery capacity to dedicate towards making this change. And so sometimes I will actually say to patients, like, I don't think now is the right time to change. Let's let some other things settle in your life, and then we can work on it. And again, maybe pick some easier, healthy habit that's not going to take as much battery, that's not as much, queued up in their survival brain. Um, when an external behavior or an external event like that switches somebody from red light to green light, it's actually typically that they're not taking care of their uncle, for example, right? They're not actually like involved in the care of their uncle going through cancer. It's just they've heard, that their uncle has cancer, and that switches their readiness for them. So that sometimes isn't about like the battery. There is no battery drain about their uncle getting cancer. It's just this awareness that it could happen to you, and that can change people's readiness. And so when people change from red light, it's often due to some external factor that has nothing to do with interactions with their healthcare providers, right? It's that kind of external event that changes their perspective on things. Yellow light to green light are things that often healthcare providers can motivate. But, red light, when that changes, it's typically some event in their external life that has shifted their perspective on it.
Hmm. So you did a lot of, care with people with really significant chronic disease. If you had a patient who had a really serious, perhaps lung condition or something of that nature, where it was really medically very, very important that they that they quit smoking, but and say they're yellow light, what would be the way that you might approach that, Dayna, in terms of sort of working with that decisional um, sort of conflict that they might be going through?
Yep. So again, you would, find out about what works for them about smoking, how it's helpful, how it's useful for them, right? What benefits they get from it, what function it serves. And then once they feel like you understand that, they feel validated about that, then we would switch to, is there anything that doesn't work about this for you? Is there anything you don't like about it? The danger of, attaching something life threatening to the new behavior is that that's what gets paired up in your brain. So now the not quitting smoking is related to death. Like that's actually what we've now paired together is that if I stop smoking, like, it's not that smoking is related to death, it's that this new behavior is related to death. Because if I don't do this new behavior, that's what's going to result in death. And so, for example, I had a patient who, had been through cancer and she wanted to start going for walks. And she's like, that will help make sure my cancer doesn't come back. Shouldn't I think about cancer all the time to motivate me to go for a walk? And I was like, no, because then every time you go for a walk, you have to think about cancer. And who wants to do that? Right? You want to be very mindful of what you're pairing up with that new behavior. Is it something positive? Is it something, value driven? Is it something that's inspiring? If you are attaching it to fear, that is what will be placed together. And that makes people stop that behavior over time. Because for that woman, she was in remission. She doesn't want to think about cancer all the time. So if going for a walk requires her to think about cancer, she's going to stop going for a walk because humans don't like thinking about, aversive things if they don't have to. So we want to be pairing it not with something that's scary and bad, not with a stick, but something that's like meaningful and inspiring for them, something about what matters to them and not again, just in the future, like you're going to have extra years of life, but how that matters to them right here and now about how they're going to show up. Right.
Mm-hmm.
For smoking, there's lots of, we've done some public health things that make smoking more difficult, right? So for example, having to smoke outside made a huge change in smoking rates because we've made that behavior more difficult to do. And so there's actually a lot of social exclusion that happens now in certain groups if you're a smoker, right? For many people, it doesn't go with their identities of being a professional or being a, high performer or things like that, depending on the culture or the environment that they're in. And so linking those things again to value-driven reasons for change about who I want to be and how I want to show up and the kind of person that I want to be in the world is something that matters right now. It's about how you're showing up today, not just something that you're going to benefit from in the future.
Mm-hmm. So, and how do you set people up for success, Dayna? So I'm recalling about 20 years ago, I had a patient who was a union steward going into strike talks. And the environment was pressure cooker, total smoking, and this was a person who had successfully quit smoking. They'd had a cardiac history and they had successfully quit smoking. And they were petrified about this environment. How would you help a person set them up for success?
Yeah, so I think it's important to not just rely on your own frontal lobe battery, right? That's a risky thing to do, especially if you're going into a high stress environment or period of time, because the stress is you're going to use up some of your frontal lobe battery to manage that stress, do all these other things that are required of you. And so, what I would encourage the person to do is to figure out how do you add extra batteries to the system? How do you add other frontal lobes to the system? And so how can you get some allies who aren't smoking? Maybe 3 out of 4 of the people are smoking in the room, but one person isn't, along with this person. Can you get some allies who are going to help you take breaks when you need to, or set up the environment differently, or still make people smoke outside versus inside, so that it's not just your frontal lobe battery that's doing it? We often want people to create environments that are less likely to prompt, smoking behavior, for example, because then you're not just relying on your own willpower. You've also created an environment that doesn't have as many cues, for example, for smoking. And so in that kind of scenario, it would be like, how do you add extra batteries to the system to help out? Maybe that's like you call a friend or your wife or something, or husband, to like talk you through a tough moment when, you're tempted to smoke, so that again, it's not just your own frontal lobe battery that you're relying on.
Mm-hmm. That's really interesting. Well, I'm excited because I've had a gazillion of my questions answered, but just a plug out there for the others who are on the line. If you have questions, please go ahead and pop them in the Q&A section. Um, yeah, but while people are doing that, Dayna, can you talk about, I thought that was really interesting how you framed the order of the questions in terms of, okay, if it was a behavior like smoking that you wanted, someone wanted to work on stopping, and you started with what was good about it, and then the flip side, okay, something that was more of a health behavior, perhaps being more active, that you asked them sort of the opposite way. How does that play out in terms of some of this motivation? Like if there's, in terms of sustaining those other kinds of perhaps more positive behaviors, what does that look like?
Yeah, so that's a specific technique that you do in motivational interviewing when people are yellow light. So when they're ambivalent for change, when there are pros and cons to change, and you're trying to help them see the pros and the cons of change. But we have this tendency to tell people about the bad things about, the unhealthy behavior. And what that does psychologically is people then kind of dig their heels in and think about the good reasons for smoking because they've been told all the bad reasons for smoking. And so it actually can make them more attached to their position because now they sort of have to defend why they're smoking. And so the technique is to not activate that defensive position by acknowledging that there are good reasons for smoking, that there are things that smoking helps them do. Most patients are quite shocked when you do that because they've heard the lectures about smoking so many times that they're geared up and ready kind of to defend their position. And so, you have to take your time with it because sometimes they're not expecting it. But because often they'll say things like, no one's ever asked me that before, right? And so you're like, yeah, but you know what? You were a yellow light. That means there's some like pros and cons of smoking. And, I think it's useful for us as healthcare providers to acknowledge, like, look, these behaviors have a function. They're often just short-term benefit, but they make you feel good in the short run. Like, yes, long-term costs, but there's something that helps you in the moment, right? And that often also allows them to feel validated that they're not, that they're in a non-judgmental environment, that they don't have to defend themselves. And then once they feel like you get them, then and only then do you say, okay, well, is there anything you don't like? Like, totally makes sense why you're smoking. It does this for you and that for you. And I can understand that. Absolutely. Period. Is there anything you don't like about it? Right. And again, in that moment, they're telling you their specific reasons that matter to them, that are about their environment, about who they are, that are problematic for them, which might be very, very different from the standard things that we tell people about why they should quit smoking. And the same thing for a behavior you're trying to get people to do, like taking medication, for example. When patients are yellow light about taking medication, the question to start with would be like, what do you hate about this medication? What's the worst part of it? What is the most unhelpful part of it? What's the most annoying part of it? What do you dislike the most about it? Right. And again, then they're going to tell you about the things that don't work for them about this healthy behavior that you're trying to get them to do. Right. And, so then you kind of be like, yeah, those are like, yeah, side effects. And it's annoying. You have to carry your pills around all the time and you can't drink. And like, that sounds like a big problem. Like, why on earth would you take this medication then? Right. Get them to convince you they should be taking this medication. Right. Like, that sounds like a lot of good reasons to not take medication. So why on earth would you then take this medication? Right. Then they get into a position where, again, now they have to defend why they should be taking this medication. Oh, no, it's really important for me to take this medication. It does this for me and blah, blah, blah. And this is important and blah, 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 blah. Right. And so, again, you're also verifying that they understand the purpose of the medication. There are lots of patients that you will say, like, what does this medication do? They'll say, I don't know. Right. So if they don't know what that medication does, like, why would they continue to take it? Right. And
Mm.
so that's a conversation, again, you would have if somebody is yellow light about taking medication.
Well, I remember you teaching me, Dayna, that in your work in transplant, that I was shocked, like 5 years out, a tremendous number of people were non-adherent to their anti-rejection drugs, right?
Yeah. So the adherence rate for health behaviors for chronic disease at 5 years hovers around 30%. And that includes things like oral breast cancer medication, right? So there's some medications that you take orally to prevent breast cancer, and you have to take them for 5 years. And at the 5 year mark, sometimes people are only at about 30% adherence. And you think, what? Nobody wants cancer. Why aren't they taking their medications, right? But that little pill every day reminds them they could have cancer. It reminds them that they could die. It reminds them they could lose everything about their life. And so if they can like not have to think about cancer every day, once they're like 4 or 5 years out from the initial diagnosis, is a normal human response to want to avoid discomfort. And so if that little pill reminds you that you could like, and get cancer again and end up dying, then people will avoid the little pill rather than have to feel the discomfort of that. And so it tells us that, 70% of people are not following the recommendations, including things like medications, which we act like is a super simple thing to do, right? It turns out it's not. And so the one thing that actually would improve people's health dramatically would be if they just followed medical advice. But telling them to do that is not how you actually get there, right?
Well, this is a really great point because Nandini had a great comment or question to me was, can we ask if someone's red light, can we plant a seed for the future? So in that state, if you had a patient, who was on anti-rejection drugs for their kidney that they finally got that was really meaningful for them, and they're red light about that because they're so fearful, to your point. Can we do anything, or what do we do? Can we plant a seed? Nandini asks. What does that look like?
So, if somebody is truly like, so I remember walking into the room of an inpatient. She had just lost her leg, like an amputation because of complications of diabetes, and she was still smoking. And so like everyone was like, oh my God, you have to get her to stop smoking. She just had an amputation. Right. And I walked into the room, introduced myself as a psychologist. And she said, I've heard it already. I don't want to quit smoking. Right. So I hadn't even said anything about smoking. She was already ready to defend smoking. Right. And she basically was like, this is the last nice thing I have in my life. I'm stuck in a wheelchair. I can't go anywhere. I can't do anything. This is the one thing that I get to enjoy in my life. Right. So if losing a leg wasn't motivating enough to quit smoking, nothing's going to be. And so if they are red light, you actually are not planting seeds. Chances are someone in the world has told them what they're doing is bad. I guarantee someone in the healthcare system has already told them what they're doing is really, really bad. And so you don't have to be the one to say that. You want to be the one that actually is like, okay, I got it. That makes sense. Again, if you have a patient who is not taking their anti-rejection medication, right? I used to work on the transplant team, and they are red light about that. You do not double down on trying to get them to take their anti-rejection medication, because what they do is they avoid all of their outpatient clinic appointments. They will not show up for any outpatient follow-up. And the only way you'll get to see them is when they come through emergency, because they're basically dying and they have no choice but to see you. That is not a good scenario. And so, what I think is beneficial is actually if other people, so, there was a case study that we did where we had a patient who was not taking her anti-rejection medication. She was booked to see me because she was non-compliant, right? She had 2 no-show visits with me because guess what? When you're not taking your anti-rejection medication, you do not show up for a psychology appointment, right? But she had 91 other interactions with the healthcare system. So if any of those people had motivational interviewing skills, which actually would not be about doubling down on her medication, but understanding why that wasn't working for her and not trying to change that behavior, she could have gotten a whole bunch of other help. But she didn't go to any outpatient appointments. And the next time we saw her was when she got admitted. And so people think that, when they're red light, that's when we have to try the hardest. It's not. That's when you have to accept that they're not ready for change and move on to something that they do want change about, right? To build that relationship, to make them want to see you again. Because then, if we hadn't doubled down on trying to change her trying to get her to take her anti-rejection medication, there's a whole bunch of other things she maybe would have been yellow light or green light for. We could have kept her going to outpatient visits, and we could have admitted her from the outpatient clinic instead of through the emergency room, right? Which would have been a much more efficient way of getting her admitted than waiting for her to be in crisis and going through emergency. And so it is the hardest thing for healthcare providers to do, but one of the most important because, again, we actually do harm. It's not a neutral behavior to try to change a red light behavior. And again, this is when they are hardcore no about all of the points, right? If they're a little bit, well, maybe I should change, right? Then they're yellow light and you have some other options to do. But when they are hardcore red light about a behavior, you want to stop trying to change that behavior and just focus on the relationship. This is also incidentally what it's like often to have teenagers. They are like red light about everything just because they're teenagers. And the goal is actually to maintain the relationship, right? They kind of go to the dark side of the moon and you're just trying to like be there when they come back. But it's very normal for teenagers to be red light about everything. No matter what it is you're saying, they're red light about it. And so stop trying to change the behavior. You're probably not succeeding anyway. You're probably just having a whole bunch of fights with your teenager and not getting them to change their behavior, right? And just focus on maintaining the relationship.
Wow. Oh, goodness. Profound stuff. So folks, just while we're just chatting here, please, we really do appreciate your feedback so much. So if you could take a minute just to scan this code and provide some feedback and enter in the draw for the gift card, that'd be fantastic and so appreciate it. And I think we have some questions in there as well, Nancy, around just whether or not, what other things you're interested in and things of that nature.
Yeah.
So Dayna, you were talking a little bit about the yellow light. And I'm thinking about a patient of mine that I've worried about over the years who's really, really, really stuck. And so sort of states that they're wanting to change the behavior, but really struggling to do so. And so, and this has been going on for many years. How do you handle that when you can just see the health status deteriorating and the stated desire to change, but the lack of follow through on it? Is there strategies for doing something different besides?
Yeah, so sometimes in those cases, and I mean, it's always a bit different, but sometimes in those cases, it's really like social determinants of health are starting to interfere, right? That they have the intention and the desire to do it, but they actually don't have the battery capacity to follow through. Again, physicians, healthcare providers on average have very large frontal lobe batteries. They are very good at self-control. You can't get through school to be a healthcare provider if you do not have a lot of self-control. But they're probably the outliers. If there was like a normal curve of how much self-control people have, healthcare providers are the outliers. They're not the norm. And so we assume that other people have as much self-control as we do, and they do not. They just do not have that much capacity for self-control. And they may live in environments that are really queuing them up for unhealthy behaviors. And so in that kind of scenario, we often want to look at the social determinants of health, what access they have to food if we're trying to change their diet, or what kind of environment they're in. If everybody else in your environment is smoking, you're going to smoke too. It's just too hard, right? If you have to give up all your social relationships, everyone in your family to quit drinking, that is a difficult thing to do, and most people won't do it. And so looking at the social determinants of health and, in a sense, understanding what else is draining their batteries. If you have housing insecurity, food insecurity, there's a huge amount of your battery is going towards those stressors, and there's not a lot left to change your own behavior. Right. And then what are the environments that they're in that are either supporting or not supporting, the behavior change, and trying to add some extra batteries to the system. So again, it's not just relying on willpower, right? I'll just try harder is not an evidence-based strategy, right? If you've tried and it hasn't worked, we need a different way of going about it that is not about you just trying harder. So how do you add batteries to the system? How do you change your environment, right? So that it's not just relying on your self-control or your frontal lobe battery.
And are you finding right now, and as you put it, in the apocalypse, is this work getting harder? Like, are you finding more people really struggling with these behaviors?
Yeah. So, I mean, during the pandemic, we obviously saw a lot of people relapsing into these kinds of behaviors. And again, there was like enormous stress on, survival brains were on fire. And since the pandemic is over, there is again a lot of stressors. There's a lot of financial insecurity, housing insecurity, right? These social determinants of health are really prominent for a lot of people. And that means that they are less capable of dedicating their battery towards these healthy behaviors, right? And again, they seem like the most important thing to us, but in their day to day lives, they're probably not the most important thing. They're not the thing that's on fire in their world, right? It's only when we see them at the clinic that they seem like this should be the most important thing, but they're probably struggling with a lot of other things. And so, yeah, people are not typically at their best in an apocalypse.
Yeah. Yeah, I love that. That was hilarious. Um, okay, well, I'm mindful that we're at time, and as always, Dayna, I learned so much from you, and I think we've had everybody has been sticking around. So I think, and we had a lovely comment in the Q&A from one of the participants saying that they've really enjoyed the discussion and your presentation. So I'm just going to speak for all of us and say thank you so much. Really appreciate you. And I just want to mention our upcoming events. We're going to have the Summit, Advancing Practice Through the Power of Partnership. Victor Montori wrote the Why We Revolt book, which is outstanding. He's one of my personal heroes, so hope to see you there. And our next L3PLP event is a 4-part webinar on head and shoulders, knees and toes, common neurologic presentations and serious mimics, starting on May 8th. And it's going to be fantastic. So hope to see lots of you there. And you're welcome too, Dayna.
Thank you.
And thanks to everyone for showing up and support for today. Bye now.
Thank you.